Morning. My name is Laura Mazer. I'm a minimally invasive surgeon at the University of Michigan. I'd like to thank the Society for the privilege of addressing you today and thank Dr. Tofai and the entire panel for including me in this discussion on a really important topic. I've been asked to talk about at-risk populations for post-herniorrhaphy pain. I have nothing to disclose. I'll talk a little bit about post-hernia pain in general, and then about the specific patient and procedural factors that predispose to chronic pain. So I think, as we all know, inguinal hernia surgery is one of the most common operations done around the world. About 600,000 or so are performed annually in the United States, and complications include bleeding, infection, sexual dysfunction, recurrence, and importantly, pain. And depending on the paper and how they're defining chronic pain, this can be an incidence of between 2 and 50%. And so the definition of chronic postoperative inguinal pain, or CPIP, becomes important. In general, it's defined as pain persisting or arising at least 3 months from the initial operation, meaning that the acute postoperative inflammation and hopefully the mesh integration has concluded. The caveat to that is that this definition is a struggle. Different studies have different specific definitions, and pain in general is a subjective finding. So it's a patient-reported outcome, but different studies tend to use very different scales. A lot of studies don't include any scale and so don't provide any degree of severity to the pain, which is why the range is so wide. And then the scoring systems that are used are often too heterogeneous for easy comparison. So we'll talk about some things that consistently show up as risk factors for pain, but sort of the grain of salt you have to take any of this literature with is the fact that the definitions of this outcome are variable. And this is something that's actively being worked on with the creation of wider registries and more standardized reporting for hernia surgeries and hernia outcomes, which will hopefully move the needle on this problem. But so when we talk about post-herniorrhaphy pain, there's actually a wide range of types of pain that can be referenced. Most typically, we think about neuropathic pain, which can be entrapment of a nerve with the mesh or with a stitch, or injury, either direct transection of a nerve or a stretch injury that will get better with time. But there's also somatic and visceral pain, and importantly, something that needs to be considered, especially if the patient initially recovers and then has new onset pain at 3 or at 6 months, is an early recurrence. So who gets chronic pain of any kind after a hernia repair? And there are a number of proposed patient and procedural factors. So we'll go through some of the literature for each of these factors and talk them through. One thing that's important to recognize are anatomic variations in the courses of the nerves. So classically, you have the beautiful Netter's diagram of the ilioinguinal nerve lying 1 centimeter away from the inguinal ligament, just anterior to the cord structures. Which is not always the case. So you can see that the nerve can be anywhere from right on top of the ligament to 4 centimeters away. And while it's most commonly anterior medial to the cord, it can be anterior lateral and medial lateral, or have no connection to the cord. And so the path, as we know from doing these operations, is variable. And certainly a nerve coursing where you don't expect it will increase the likelihood of injury to that nerve. Similarly, the iliohypogastric nerve, this is a cadaveric study looking at 100 different cadavers at the retroperitoneal courses of these nerves, and you can see how variable the course really is, and the insertion points are really scattered throughout the entire region. The genitofemoral tends to be the most consistent in its course, and in 100% of cases, it is always medial to the iliohypogastric and the ilioinguinal. But the other nerves are in a typical distribution in less than 50% of cases. So certainly anatomic variation plays a role. But demographic factors are also risk factors for chronic pain after inguinal hernia surgery. Consistently in most studies, younger patients tend to have higher rates of chronic pain, and younger usually means less than 40. Gender has been suggested, so most textbooks will list risk factors for post-hernia pain, and female gender will be on that list. It's a little bit tricky to say because so many of these hernia studies only include men, and so many of the biggest studies that give us the best data are male-only studies because hernias are so much more common in men. But that means that it's a little bit harder to say that female gender is a risk factor. It is in some studies, but there's also some concern that it may really be a confounder for other factors. And then BMI similarly is not always reported, but has sometimes come out as a risk factor. So higher BMI may predispose to increased incidence of chronic pain. So the hernia itself plays a role as well. Smaller hernias and occult hernias, meaning clinically not apparent until you're in the operating room, have a much higher incidence of chronic pain. And so there's some question as to whether or not gender is actually a confounder for hernia size, because women tend to have smaller hernias and have a higher rate of occult hernias. And since smaller occult hernias lead to increased pain, gender is often not considered. Is gender a true independent risk factor, or is it, a confounding variable with hernia size? We probably don't yet have enough data to say. But recurrent hernias are certainly a risk factor for postoperative pain, which makes sense. It's a reoperative field. And similarly, bilateral hernias have a higher incidence since it's twice the operation and twice the chance to risk a nerve. And then finally, one of the strongest risk factors is preoperative pain. And depending on the study, this is defined differently, but essentially any pain pre or in the immediate post-op period predisposes to higher incidence of chronic severe pain. So preoperative hernia pain, a poorly defined groin pain syndrome, any history of chronic pain syndrome, chronic pain after a prior operation, higher postoperative pain medication usage, higher acute postoperative pain, like needing more medication or scoring higher on a pain scale in the first couple of days, and any chronic narcotic usage are all related to a higher incidence of chronic groin pain after surgery. So moving away from patient factors, there are also a lot of procedural factors that impact your likelihood of developing chronic pain. And so on this side, you can see, the course of the nerves with an open inguinal hernia repair, which is a little different from viewing it from the posterior approach in a laparoscopic repair. The nerves that you're most likely to injure may differ. Rather than the ilioinguinal, the genitofemoral becomes the most likely to be injured in the laparoscopic approach. And the surgical approach is a consistent risk factor for postoperative pain. So consistently the open approach, and this is the classic 2004 New England Journal paper, the first big study looking at open versus laparoscopic. And one of the outcomes that didn't get quite as much attention as the recurrence data is the incidence of postoperative pain. So long-term neuralgia or other pain is actually significantly higher in open surgery than in the laparoscopic repair. And this has been consistently found in subsequent studies. So this is a 2010 randomized trial of about 1,300 patients, and you can see at 1, 2, 3, and 5 years out from surgery, the Lichtenstein mesh repair has twice the incidence of chronic pain as the TEP. And a Cochrane review of 41 studies agrees this is for TAP versus open, showing a benefit to TAP for chronic pain, and this is for TEP versus open, showing a benefit to chronic pain, and when they're pooled together, there's still a benefit to the laparoscopic repair. So then the suggestion was, well, perhaps the mesh is related to chronic pain, and there have been a lot of people who've suggested maybe a non-mesh repair has less pain. This is a Cochrane review of Schuldeis, so a non-mesh open repair versus mesh open repair, finding no difference. So they don't conclude that there's any protective factor doing a tissue repair specifically for chronic pain. There may be a benefit to a lightweight mesh. So this is another systematic review looking at lightweight versus heavyweight in a Lichtenstein, and there is a benefit to a lightweight mesh for chronic pain in this cohort. In another review looking at TEP repair, so now a laparoscopic repair, they found no significant difference in chronic pain for heavyweight versus lightweight, but heavyweight did have a significantly higher incidence of a foreign body sensation. And finally, we talk a lot about surgeon expertise in terms of a laparoscopic hernia repair, but it impacts open hernias as well, obviously. And so this is looking at expert versus novice just for a Lichtenstein, and you can see a much higher incidence of chronic pain in the novice group. So to conclude, who gets chronic pain after a hernia surgery? There are some things that we know are risk factors. A younger age, open surgery is a risk factor for chronic pain. A recurrent hernia, a small or occult hernia using sutures or tacks rather than no fixation or glue. And again, this is just for chronic pain, and any preoperative pain syndromes. Female gender, maybe. We need to continue to investigate, and female gender needs to be more reliably included in hernia studies. Higher BMI, maybe, and heavyweight mesh, probably. So it's worth considering for people with multiple risk factors, additional context and counseling preoperatively, and potentially approaching those people preferentially with a laparoscopic repair. And thank you very much.